Hi, I'm Dr. Paul Sachs. I'm Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital, and I'm going to be presenting COVID-19, an update for clinicians. I have no disclosures. So let's start out with a look at the epidemiology. What happened and what's happening now? If we take a look back to when this first started, it all began likely in late November, where their intelligence picked up reports of an unknown pathogen in China. However, it wasn't until December 30th of 2019 that ProMed, which is an online site that looks for outbreaks, reported an undiagnosed pneumonia in Wuhan, China. The next day, the Chinese government released the first official report, and then January 2nd, the WHO led an investigation. Already by January 7th, a novel coronavirus had been identified, and it was genetically characterized very soon after that. Amazingly, just 2 weeks after the first report, we had a diagnostic PCR test, which was published a little bit later. And later that month, the first case occurred in the United States in Seattle. The next case was in China, and both of these cases were linked to people who had been to China. Later in the month, China was closed off, in particular Wuhan. And then in January, we had the first documented human-to-human transmission outside of China, which occurred in Germany. And then we had similar transmissions in the United States. So when we go back and look at that first report, it's hard to imagine that it would become a global pandemic, but here it is. I have it on the left of this slide. Published date, December 30th, 2019, undiagnosed pneumonia in China. And then Helen Branswell, who is a sophisticated medical reporter for Stat News here in Boston. She investigated SARS and MERS and Zika. She posted on Twitter on January 2nd that she's, quote, not liking the looks of this, and this turned out to be very prescient. So what has been the problem, and why are we in such bad shape here in the United States with COVID-19? Well, we have not had any federal coordination of our response. In addition, the CDC, which usually is very front and center in all such outbreaks, has been doing relatively little compared to other outbreaks, meaning they've been sort of sidelined. You don't hear from them on a regular basis. The way our country is structured, some have described it as 50 states with 50 countries. In addition, this has really exposed health disparities, and we know that COVID-19 is occurring far more frequently and also more seriously in people of color and people in poverty. And then probably the biggest problem was that our testing was delayed. We did not adopt the WHO test. We still don't know why we didn't. The FDA had a very slow and burdensome process for individually developed tests at laboratories, and so nobody came forward with a test that they could use. In fact, the first case was identified in Washington because one of the labs decided to go forward and do the testing without FDA approval. And the CDC did release a test, but it was limited in volume and also flawed. It had errors. So for the entire month of February, as this was spreading around the United States, we actually did not test for it much at all. And we ended up losing significant ground. So by the end of February, by February 29th, is a leap year, we had 368 tests performed in the United States, and there were 60 positive tests. Looking back now, epidemiologists have modeled and said that we actually had approximately 10,000 cases at that point already. And obviously those 10,000 cases were being undiagnosed and were allowing the spread of the virus to go elsewhere. Well, since then, our curve looks like this. There was a sharp upslope in March and April, and then we peaked in late April in northeast part of the United States in particular, and other large urban areas. And then we started to see a decline, which was actually quite encouraging. And the decline, though, was halted. And unlike the European Union and Canada and in Australia, where the declines continued, our actually COVID-19 case numbers are increasing. And why is that? Well, it turns out that it's increasing because we see in some states, like Massachusetts, behavioral change has led to a sharp decline in the number of new cases. And at our hospital, we've declined from over 200 cases at one point to being under 20. And you can see that this has been very steady. And this is true also in Connecticut, New Jersey, New York, Illinois. Many states in the United States are following this curve. However, in other parts of the country that initially did not have nearly as much COVID-19, they have seen a sharp upslope. That's a combination of increased availability of testing, but also, unfortunately, increased number of cases. related to the primary things that I'm going to review in the next section, which is how this virus is actually transmitted. So let's talk about the virology and the transmission issues. This is a coronavirus, and we knew about coronaviruses before the current coronavirus, which is called SARS-CoV-2. Now, there are 4 circulating coronaviruses. They are found on some diagnostic panels, and they do not cause COVID-19. They do, however, cause approximately 10 to 25% of community cold-like illnesses. Very rarely they're severe, and we can sometimes see them in our immunocompromised population, and they're quite seasonal. They have a peak incidence in the winter months. We know about SARS coronavirus 1, which called SARS in 2003, and MERS coronavirus in 2012, and they did cause very severe outbreaks of pneumonia, especially in hospital settings where they spread from the people who were sickest, sometimes to healthcare personnel or to other patients. Both of these are linked to an animal reservoir, and they are all genetically distinct from SARS-CoV-2, the cause of COVID-19. So how does COVID-19, why does SARS-CoV-2, why did it spread globally and the others didn't? Well, the predominant reason is isolated in this table. If we compare the COVID-19 virus, SARS-CoV-2, with SARS and MERS, we have quite a lot of asymptomatic, or really more accurately said, pre-symptomatic transmission. And the other thing is that the peak viral shedding occurs early on in this illness, unlike in SARS and MERS, where the amount of virus is actually highest in the sickest patients. So that allows for this virus to spread in the community before people become sick, or even when they're not very sick at all. And it leads to these so-called super spreader events, which are the dominant way that this has spread around the world. So how is it transmitted? It is almost all transmitted person to person via respiratory droplets. There is also extensive surface contamination, in particular in the rooms of people who have this infection. So these droplets, they typically are released when people are coughing, sneezing, singing, speaking, and then they fall to earth pretty quickly, and they don't get dispersed very far. I mean, obviously there are exceptions. If someone sneezes or coughs and the ventilation in the room is poor, it could go further, but typically fall pretty quickly, which is why distance between people is so critical for preventing the spread of this infection. There are some aerosols, which are very small and they float in the air, that might contain the virus for very long. It's controversial to what extent these aerosols leading to transmission. We know that aerosols spread infections such as measles and a highly contagious case of tuberculosis are actually more contagious than COVID-19. So the take-home messages to avoid infection: avoid crowds, wash your hands frequently, don't touch the face, clean contaminated surfaces, and then encourage mask use in public, predominantly because asymptomatic people or pre-symptomatic people could be spreading the virus without knowing it, and the mask actually reduces that. So this is an excellent poster that is from China, but it's nicely done in Japan. Avoid the 3 C's: closed spaces, crowded places, and close contact settings. These are the highest risk environments for the spread of SARS-CoV-2 and for the spread of COVID-19, the disease, in our communities. Super spreader events provide us some information about just how bad this can be. This is a call center in Korea. And if you take a look at this floor map, every blue seat is a person who developed the infection. And there was an index case in this region of the call center. You notice that these other call center seats, very few people got infected. So it takes crowding, yes, but it also takes poor ventilation, and it takes an index case. And that is predominantly how COVID-19 is spread, not on surfaces, even though I will talk about surfaces. So this phenomenon where one or a few people infect many, but most people infect very few, is called overdispersion. And so in one study from China, 9% of the infections resulted in 80% of the other transmissions. And they typically were in settings like bars and restaurants and churches and nursing homes and some large households, large crowded households. These super spreader events, one of them happened here in Boston. It was at a biotech conference where over 100 people were infected. And these are very important, and preventing them is critically important. This overdispersion gives us an opportunity to reduce the spread of the virus by reducing crowding in these high-risk settings. So let's talk a little bit about surfaces. We can find the virus in multiple locations. We can find it not just in respiratory secretions, but also in in the stool and blood, in conjunctival fluid, in vaginal fluid. We can find it even in our pets. And this, of course, gives me a chance to show you my dog and my cat. That's Louie, the dog, and Otto, the cat, wanting to come inside. And I've kept them outside because both of them are infected with the virus that causes COVID-19. I am just kidding. No, I just want to say that even though animals can acquire this virus, there is no evidence of any animal to human transmission of this virus thus far. So I would not worry about that. How about environmental viability? This is a paper that was published in the New England Journal of Medicine that got extensive, widespread media attention, and I think has been a little bit overblown in the importance of the epidemic. They took the virus and they sprayed it onto various surfaces. You could see copper, cardboard, stainless steel, and plastic. They found it lasted 3 days or more on stainless steel and plastic, a day at least on copper and cardboard. I don't know why they chose copper. It's not as if we use that surface very often. And people then took this as basically that means they have to wash their groceries before they put them away. They have to put their packages from shipping companies in quarantine for 3 days before they can bring them into the house. None of those things really has been linked to spread of this infection. And so at least personally, and most of the infectious disease doctors I know don't do any such thing. So even though, yes, it can live on surfaces, I think the key thing for surface decontamination is if you are caring for someone in your household who has COVID-19, then those surfaces should be decontaminated. Or if alternatively, you're working in a hospital setting, cleaning the rooms after a patient is in there with COVID-19 or cleaning the rooms period after patients are in there makes sense. So what about masks? I want to focus in this chart here. We're going to look over here at this part of the chart. You can see these aerosols, and they are without a mask. They're spreading up here, and with a mask, they're not spreading. This is coronavirus, and it's actually very encouraging to see this. We now really understand better that wearing masks does reduce the spread of the virus to others. Does wearing a mask protect you? Probably somewhat. Obviously, N95 respirators are more protective. We reserve those for people who are doing high-risk procedures, especially for people doing high-risk procedures on individuals who have COVID-19. So if you take a look epidemiologically, countries that have actually used masks from the start have tended to have a more favorable trajectory of COVID-19 than other countries. And the Czech Republic in particular has a very impressive YouTube video about why people should be wearing masks. If you have any doubters out there among your family or friends, they should watch this, and it is actually very persuasive. So when are people most contagious? The viral load in the upper airway peaks around the time of symptom onset. In fact, it peaks just before it, about 1 day before it. I think if we all memorize this curve, we would understand why it's so critical that people wear masks in public during this pandemic. So a typical story will be someone feels fine on a Friday night. They go to a crowded bar or restaurant. They're talking to their friends. They're having a few drinks. The next night, they might have a little tickle in their throat, not feeling quite well, but well enough to go out. And then Sunday, they spend the day in the bed coming down with COVID-19. That person was contagious for those exposures and is really important in contact tracing. Okay, shifting now to clinical manifestations and diagnosis. This has an average incubation period of 4 to 5 days from exposure. That's when symptoms start. And 98% of people will develop symptoms by day 12. There are very rare exceptions. The most common are the symptoms that you all recognize as very common with viral respiratory tract infections. So I'm not going to read them all. I will highlight this one. Anosmia turns out to be an extremely important side effect, symptom of COVID-19, very common, even more common than the common cold. But there's a whole host of other things that have been reported: conjunctivitis, rashes, neurologic symptoms, coagulopathy, myositis, myocarditis, renal failure, proteinuria. This is a virus that really can attack pretty much any part of the human body. Importantly, initially people often do not have a lot of dyspnea, but if they develop more shortness of breath 5 to 10 days into the illness, it can herald an immunologically augmented clinical worsening. And sometimes it comes on fairly gradually so that patients don't notice it, which is why ideally, if someone has a diagnosis of COVID-19, if they could have an oximeter at home to monitor their oxygen, that really is ideal. Another thing I should mention that's very common is after people recover from this illness, they have a profound and prolonged post-illness fatigue. And then I can't avoid mentioning these COVID toes. These seem to be more common in younger individuals. These are probably a microangiopathy that occurs secondary to the virus. Very much not necessarily associated with a poor prognosis, just something that's been observed quite a bit in the community. So this was a nice description of cases as they were introduced into Italy. People with mild symptoms had a very high viral load despite these mild symptoms and recovered after about a week. They had a clear chest x-ray, but a dry cough. A sort of biphasic illness is the one I described, where people start with a dry cough and fever, and then they develop chest x-ray abnormalities or CT abnormalities. And then sometimes they actually got worse. And when they got worse, their actually viral load was lower in their respiratory tract. It suggests that non-viral processes at play in the second phase of disease. And in the worst case scenario, people have multi-system involvement, incredibly high inflammatory markers, organ failure, and they go on to the ICU and sometimes die. Our interventions are going to be sort of challenged by this viral and versus immunologic phase of the illness. And I thank the medical students at Emory University for putting together this amazing figure. So when you're looking at the labs, these are the things to watch out for. Profound lymphocytopenia is very common on the CBC. The procalcitonin, if you're using that in your institution, is almost invariably low. D-dimer, ferritin, C-reactive protein, sky high, some of the highest CRPs I've seen, especially in sick patients. And the D-dimer is sometimes reflective of an underlying coagulopathy. So let's talk a little bit about this. I say hypercoagulable state, but it's really a disorder of discoagulation. When people have a very high T-dimer, it's predictive of venous thromboembolism and also a higher risk of mortality. Sometimes it's associated with antiphospholytic antibodies. And although venous thromboembolic disease is more common, arterial thromboembolic disease has also reported. And sometimes it occurs in ICU patients, even with full prophylaxis, which has prompted some institutions to institute a more aggressive prophylaxis for bleeding, for clots. However, there have also been bleeds related to this illness. So I want to mention that there are some case series that include some really disastrous arterial clotting episodes, including ischemic limbs and cerebral infarcts, very devastating, in particular in some cases in young people. So when you worry about COVID-19, there's a lot of comorbid illnesses that might actually be associated. And I'm going to actually include pregnancy in this list for the first time, because the CDC just issued some epidemiologic data saying that pregnancy was associated with more severe COVID-19. But hypertension, obesity, diabetes, CAD, COPD, they're consistently reported. But the one that is most important is older age. If you take a look in study after study, in region after region, the older you are, the more likely you are to have severe COVID-19. This is not like influenza, where you have a young peak and an old peak. It's certainly not like 2009 pandemic flu, where a lot of younger people got this, or like the 1918 flu. And that was really sad, because as young adults, years of lost life was huge. The average age of the person dying with COVID-19 in Massachusetts is 81 years old. In our inpatient COVID-19 floors, sometimes the average age was 75, 80. Now, there are exceptions. Some young adults, some children get very severely ill with this infection also. They're very widely publicized, but I really want to emphasize that they are the exception, not the rule. We don't know yet why infants and children are mostly protected. There is some data from South Africa that HIV is a risk factor for more severe disease, but most European and US studies don't show this. And then we don't know yet about more broader types of immunosuppression, such as biologics, cancer chemotherapy, and asthma. There are mixed data. So I do need to talk about asymptomatic infection. It is highly variable. I cite on this slide the cruise ship investigation, where 45% of the individuals were asymptomatic when they tested positive. And then in admitted to the New York City hospital during peak incidents, pregnant women, of those who tested positive, 88% had no symptoms at all. However, by contrast, in a nursing home in Seattle, only 4% remained asymptomatic during the entire course of the illness. So the key determinants of whether someone's going to be symptomatic or not are age, the intensity of exposure or the inoculum. And you have to really distinguish between asymptomatic versus pre-symptomatic. The pre-symptomatic people are the ones who are likely transmitting the virus the most. The asymptomatic people, it is really uncertain how much they're responsible for this transmission. We make the diagnosis of someone acutely ill predominantly with this rather uncomfortable procedure, which is a nasopharyngeal PCR. And you can see that from the figure that the actual swab has to go fairly far back posteriorly to get the tissue, to sample the tissue. The challenges have been regulatory, as I mentioned. Healthcare workers doing this procedure need to be protected. The supply chain has been disrupted several times during the course of this epidemic, most recently in Arizona. Getting a good specimen is difficult for the reasons shown here. Turnaround time initially was terrible in Massachusetts. We sometimes had to wait a week for our results. Now it's much faster. And then also, we can augment this with serologic testing. So the test is highly sensitive and specific. The clinical sensitivity varies, and that depends on the quality of the specimen collection, as I've mentioned, and also the time point in the disease when the specimen is obtained. The virus starts in the upper airway, then moves lower in people who are developing pneumonia. And so if a test is negative and you strongly suspect the disease, you have a bunch of other options to try to make the diagnosis. One is to repeat the nasopharyngeal PCR. That's certainly what we do. The other is to obtain a lower respiratory tract sample if your lab can test for sputum or endotracheal aspirates. Chest CT can identify very characteristic ground glass opacities in a significant fraction of people with symptoms, and even in some people without symptoms, and that gives you a presumptive diagnosis. And then there's serology, and I'll mention serology in the next slide. Here, you can see that over time, down here at days 5 of symptom onset, about 50% of people are seropositive. There doesn't seem to be much difference between IgM, IgG. And so right now, I can't see a big difference between the two in most studies. And then by day 20, nearly 100% of seroconverted. So that's good in this assay. Antibody levels tend to increase over time. We don't know yet whether these antibody tests suggest that people are protected from future infection. Certainly that's hopeful, but this can augment diagnosis if you have a negative nasopharyngeal swab and you're suspecting the disease. So before I leave diagnostics, I have to talk about prolonged PCR positivity. Some people, it lasts weeks. It does seem to be more common in people with severe infection, but sometimes it is seen even with mild illness and complete recovery. And I have to say, this man who was on the Diamond Princess cruise ship and happens to be a very publicly minded individual, he developed COVID-19. He had 1 day of symptoms. That's what he said. He had fever and chills for 1 day, made a complete recovery, and tested positive for nearly 2 months, and was in quarantine as part of a study the entire time. No symptoms at all. It really created challenges with return to work policies. And how do we address those? Well, what we've learned is that most of these cases, in fact, all of them, there's no replication competent virus detected in these people who are PCR positive and more than 10 days after their symptom onset. So the best study comes from Korea. They looked at a large number of these individuals who had PCR positivity for a long time and found no secondary transmissions. And so this allows for a time-based cessation of infection control. And here's our hospital policy. It's a little bit on the safe side. If one of our employees, any employee, has symptomatic COVID-19, and they are at least 3 days since recovery, and at least 14 days since after symptom onset, they don't require any further testing before coming back to work. We are confident that they can return to work without infecting other people. And this is based on CDC guidance and public health guidance. And in fact, CDC guidance says 10 days, but we've put it to 14. So let's talk about treatment. So a whole host of treatments are out there. I've listed the antivirals on the left, including convalescent plasma from recovered patients. I've listed the immunomodulators on the right, including corticosteroids and a variety of much more expensive and fancier immunomodulators like IL-1 inhibitors, IL-6 inhibitors, intravenous immunoglobulin, JAK inhibitors. I didn't put in complement inhibitors. We don't really know yet the best approach, but we've learned some things. And let's focus first on the figure that shows that first phase where the viral illness predominates, and the second phase where there's an immunologic illness predominating. We might be able to target these two different areas. And I think our first two effective treatments actually do this. So to start with remdesivir, this is our first treatment. It's still investigational, although it's available through something called an emergency use authorization. It did not work very well against Ebola, for which it was originally developed. And it initially had some plus minus results. We couldn't really tell. The studies were flawed. But then an NIH-sponsored study in late April was stopped early by the Data Safety Monitoring Board. They found that people who received remdesivir actually recovered faster, 4 days faster than the placebo arm. And 4 days may not sound like a lot, but for a viral respiratory infection, it's actually fairly prolonged. You know, in influenza treatment, we have recoveries that are faster by 1 to 2 days on average. So this is the study. Patients who were 18 or older and admitted to the hospital and had infiltrates and had oxygen requirement or were on mechanical ventilation, 1,000 randomized to receive remdesivir or placebo. And then they had a primary endpoint, which is time to recovery. And they used day 29. It was initially day 15 or earlier, but they realized that people with severe COVID-19 often took longer to recover. This is what they showed, the median recovery time, 15 versus 11 days, and they nearly showed a mortality benefit. I think they may when they ultimately finished doing the analysis. It did not appear to have any serious adverse events of note. So remdesivir is very promising. It did not help people who were mechanically intubated or on ECMO. And then we have another treatment that was just reported as effective, and that's dexamethasone. This is the recovery study, open label study of dexamethasone for 10 days versus usual care, 6 milligrams per kilogram, for people presenting into the hospital. And the study was halted because the steering committee overseeing the study found convincing evidence of mortality benefit. And this is the slide right here. This is highly statistically significant. They did not see a benefit in people who didn't have any oxygen requirement. And that's important because obviously giving steroids is not a benign thing to do, especially in an infection. Now, this study has not yet been peer reviewed, but I probably will be by the time you're listening to this talk. Then let me also mention tocilizumab. Tocilizumab is an IL-6 blocker. It's been used quite a bit off-label, and there are a bunch of uncontrolled and observational studies out there already published. It is not a free lunch on multiple levels. It is an expensive drug, and also it could be critical to the host response to clear the virus and clear secondary infections. So we are not sure exactly where to go with this. Right now, there is a controlled trial that's been reported from France that showed a favorable outcome, but we don't have all the data. I just put the tweet that's up here. It was a press release. In addition, there is a fully enrolled moderate disease study that we should get data on soon. Now, I just briefly want to mention how difficult it has been studying these interventions. Right in the middle of a pandemic, a lot of things get tried, a lot of anecdote. Hydroxychloroquine has in vitro antiviral activity and also may improve the inflammatory response. But the randomized trials, the highest level evidence, have been disappointing. None of them has shown any benefit. In addition, it was tested in post-exposure prophylaxis and also didn't work. So right now, hydroxychloroquine is not recommended in any of the guidelines. So this brings me towards the end of my talk. I'm going to mention some ongoing questions and where to get reliable information, and then I'll finish up with some questions. So one is, how long are asymptomatic people infectious? I mean, the truly asymptomatic people, we really have no idea. Why do some events or people involved in super spreader phenomena and others aren't? Babies and children, I mean, it's not just that children don't get as severe disease, but some studies show they don't even get the infection very much at all. And remember, kids are often like the petri dishes for respiratory viral infections, but not this one. They might have some cross immunity from other coronaviruses. We do see worse outcome in men than women. We do wonder whether this is going to come back in a big way in the winter. We also wonder whether infection causes immunity, and if so, for how long. We don't really understand the inoculum effect. It does appear that more exposure leads to more severe disease, but we don't have proof of that. And then how should we use serologic testing, both as a public health measure and as a kind of return to work phenomenon? Can we develop a vaccine? Lots of very smart people working on it, and I'm certainly hopeful that we can. So here's some sites. I do think the CDC does still have some good information and a lot of very smart people working there. I'd like to see them play a bigger role in distribution of this information nationally, and I hope they will. The ID Society of America, idsociety.org, the COVID treatment guidelines from the NIH, Johns Hopkins Coronavirus Resource Setting has been doing a great job in keeping track of some of the numbers. And I want to call out to my local Stat News. This is a Boston-based affiliate of the Boston Globe that does really outstanding medical reporting. I can't recommend them highly enough. So, which of the following has been consistently identified as a strong risk factor for severe COVID-19? I'll let you think about it for a moment. I got 4 answers here: asthma, HIV, cancer, and age. The answer here is clearly D, or age. The other 3 are possible. I mentioned HIV with our South African study showing that HIV was, but European and American not. Asthma, it's not clear. And cancer chemotherapy, it's also not clear. Now here's a case: a 65-year-old man with obesity, hypertension, and diabetes presents with fever, cough, shortness of breath. A nasopharyngeal PCR is positive for SARS-CoV-2. He's not ill enough to require hospitalization. Which of the following statements is true? A, his peak level of infectiousness is just before and in the first few days of his symptoms. B, only when he has a negative nasopharyngeal PCR will he no longer be infectious. C, he can return to work once he no longer has a fever. D, he should wear a mask even while home to prevent secondary infections from other viruses and bacteria. And the answer, of course, is A. We now know that the peak amount of virus is in the day just before and the days just after onset of symptoms. So that brings me to the end of my talk. This has been Paul Sachs speaking to you about COVID-19 for clinicians. Thanks very much for listening.